Daily Dose of Dopamine. My name is Robert, and I am joined here by Dr. Okeanis Val. And I had the pleasure of meeting her at the All In, the PMD Alliance All In, back in late November. Actually, I got to meet you briefly, introduce you after I forgot to introduce you. Larry says, "Hey, you might want to get Dr. Val," because you were presenting together. I was like, "Oh shoot," and got to watch you and Larry do a fantastic presentation. Why don't you open up with a little bit about that presentation? That was about sleep, which is an underreported part of Parkinson's and health in general. It's part of your specialty. Tell me why it's important. Why should people care about sleep and Parkinson's?
Yeah, well, first of all, thank you for inviting me over. It's my pleasure. And whenever I get invited to speak about Parkinson's sleep, my eyes light up and I get so excited. Actually, it is very important for many reasons, but I just want to share. I just saw a patient literally an hour ago. He came new, he was seeing another movement specialist, and I started going through the questions I usually ask, and then I get to sleep and I go through sleep with all the details that I want to know. And the patient wasn't interested. It was getting a little bit upset that I would think we're not, why are we even talking about sleep? This is not, like I have Parkinson's. You're telling me about sleep, even though we've had gone through all the details. And then I had to pause and say, well, let me explain to you that sleep is extremely important for everyone, but especially for Parkinson's. So it's something that is still not, we no matter how much we talk about sleep, it's not still not out there how important sleep is in Parkinson's, which is the most one of the most impacted functions that one has with Parkinson's. I barely see patients, I very rarely see patients telling me, oh, my sleep is great. There's always things that happen in
Yeah.
sleep early on, 10 to 15 years before the standard, Parkinson's symptoms start, the motor symptoms as we call them. And we got to start from there. We got to start talking about the REM behavior disorder, the acting out of dreams or nightmares, as
Yes.
people talk about. And yeah, sorry, what you were going to
No,
say.
no, no. You're great. This is wonderful. And I wanted to say, are you affiliated at all with the folks at Acadia and that More to Parkinson's campaign? Which I think it's telling a similar thing. I mean, I know they're more about the hallucinations and delusions,
Mm-hmm.
as opposed, but it's that's related in a way. I just want to say I love the fact that what you're doing is similar to what they're doing, expanding beyond it being called a movement disorder. I mean, that's the problem. One of the problems, in my opinion, of it being encapsulated here. It's like, well, your patient is irritated. Why are we talking about this? Because it does affect this, and so does this, and so does your interactivity and your communication, your socialization. Um, I know I said about three things there. What do you think about that idea of more to Parkinson's, expanding the definition?
Oh, absolutely. I mean, we've been saying that for over and over again, and we have to approach Parkinson's in a holistic manner.
Yeah.
It's not just your tremors, and actually, it might, in many ways, we know a lot on how to treat motor symptoms, but there's so many things we don't know and do well enough in terms of treating the non-motors, the blood pressure control, the sleep aspects, the cognitive aspects, the hallucinations that you just said. So it is, you have to really, and I get it, it's time consuming. So patients come for a follow-up for half an hour. You have to talk about all these problems. And most of the times, every single domain is needs attention. So if I could, I would love to sit with about like an hour with each of my patients to talk about it. But it can be challenging. So I
I was gonna
usually go in and say, tell me three things that bother you most.
Sure.
Talk
A
about
clin
this time.
So there's your clinical challenge. And for those who don't know your world as much, I mean, do you, and every institution is different. Does yours give you a limit of how long you're allowed to, or do you get to kind of feel it out about how long you get to spend time with each patient or?
Well, there's always a limit, and for everyone, no matter what, where we work, what institution, private, for-profit, nonprofit, solo practice, you always have a limit.
Yeah.
Of course, the limit, you never say, oops, 30 minutes are up. I have to say goodbye and see you next time. You can't really do that. But that's, you have to set the standards of how the visit will be and what the pressure is that, um, that's why I like to structure and say, what are the most important things you want to talk about? Meanwhile, leaving at the end the ones that are probably doing well. So, I will run through the symptoms, making sure everything is okay.
It sounds like, yeah, you have to do some fact finding. You have to be kind of a story coordinator almost for, give me these things and let's see if we can order them. And then, we can place, the things I can do versus maybe the things that, are lesser. That's a juggling act in and of itself. I want to get back on our next episode because believe it or not, it's been 5 minutes already. To the particulars of sleep because I'm fascinated by it and I don't know enough about it because it's not just people with Parkinson's, obviously, it's all of us. But since that's one of your specialties, let's come back in the next episode and talk a little more about sleep in particular. Okay.
Yep,
All right. See you in
absolutely.
our next dose.